But I don't want anybody to say, this can't be done. It's impossible to sequentially distalize those teeth or to bring these into the right position or to whatever. The main point is that I just want you to have that information. We cannot rely on just the condyle repositioning itself as we fix the retroclined teeth, right? We have to do something else if we want to correct this to class 1. And so because we do, we're going to use the technique of this sequential distalization. Okay, so here is our second case. It is going to be faster than the last one. Now, some of the things you've already seen, so I'm not going to hit on them quite so much, but this patient comes to our practice. Her initial concern is she comes in saying that she doesn't like her front teeth. But the second component here is she says, this tooth is really, really wiggly. And I think it's about to fall out. And she's panicked. She's in her 20s. She's 24. What she doesn't realize is that she actually has a canine underneath that tooth. She grew up in Eastern Europe. And so because of that, what are our options? Well, we talk about option number 1. I mean, we could do nothing. But that baby tooth is about to fall out any day. We could instead extract the baby tooth and place a bridge, but a bridge to a lateral incisor sucks. We can't place an implant because when we look at our positioning, there's no bone, so we can't do that. Or we could orthodontically bring that tooth into the mouth. And so that's what we talked to her about, and that's what she decides to do. Is she says, yes, I want to go ahead and do orthodontic treatment. I think that makes the most sense because I don't like the position of my front teeth. What's also happening is, a little bit hard to see here, there's chipping and wear that's happening on all these front teeth, right? Because she's biting right now with a retroclined anteriors in a deep bite. And so because of that, she's damaging her teeth. We look at her lower premolar, and this one's rotated. She has the crowding on her teeth. And so we also evaluate that she's biting in a slight class 2. Well, not slight class 2, she's like end-on molar class 2. So what are we going to do? Let's go ahead and take a look at her clin check. Well, the first things that we're going to evaluate is, I mean, you guys saw it before, CC-adult. We'll pull up our template and we'll work through it line by line. The end of treatment. Okay, so what are we going to start with here? Technician's comments. Was there anything specific? I'll tell you right off the bat, there is not. Is the bite set properly? Yes, it is. Do we have 4 passive trays at the end of treatment that aren't moving anything? We actually do, so that's perfect. Okay, final bite position. Let's turn off our attachments. Who cares about our attachments right now? We're just looking at the final positioning. Are we correcting to class 1 molar and canine? So here's the debate. This patient right now, if we were not correcting her to class 1, if we were not adjusting anything on her, as we procline these teeth, her overjet is going to get more significant. Because as we decrowd these teeth, they're going to procline forward. This patient knows that she has a long path in front of her, right? Because this tooth is impacted, it's going to take us 1.5 years to maybe even 2 years to pull this tooth in. That's it for sure. And so us saying to her, hey, here's the situation. We can go ahead and pull that canine tooth in and we can straighten your front teeth, but your front teeth are going to move forward quite a bit and you're going to have a really big overjet. Normally our patients just call it an overbite, so I go along with it. You're going to have a big overbite. So what can we do about that overjet? Well, we can back the teeth up 1 tooth at a time. Right? But to do that means that we're going to have to use elastic rubber bands and it's going to take time. But in reality, your case is going to take a while anyways because you have this stuck impacted tooth. And so we talk about we could not move anything in the back or we could. And she says, well, you know what? If we're going to put the time in, I don't really care because we're doing it anyway. So let's go ahead and focus on moving the teeth back. And so that's what we are going to look to do here is that we are going to be finished this patient in class 1. But the method that we're going to do, and because I don't want to take an hour going through this case with you guys here, I'm going to show it I'm going to jump back and forth more to our actual plan of what we did here, is we're actually going to sequentially distalize and bring back those anterior teeth by moving the teeth one tooth at a time. So second molar, second premolar, first premolar, and then the anteriors. And I shouldn't quite say one tooth at a time because it's actually moving two teeth at a time. It goes second molar and first molar at the same time. And then that first premolar does not start moving until the second premolar, the 1-5 does not start moving until the 1-7 is done. And then the 1-4 does not start until the 1-6 is done. And by doing that, that's the most consistent way of backing the teeth up. But our goal is here that at the end of treatment, she's biting in a perfect class 1 occlusion. Again, some of you might need to jump and go. So let's just go ahead and I'll spoil the ending already and just show you guys some of these things. So here's where she's at, class 2 end on, impacted canine. So for anybody who has to go, let's go to this one here because it's a bit better photo. Here's the patient at the end of treatment in perfect class 1, molar and canine. The canine is in, we've brought it in. The overjet is good. Her midlines are spot on. Her deep bite is fixed. I guess this one's actually the better one to show. Her arches are developed. The canines are rotated in the right spots. So I just want you to see, and this premolar here is rotated back into the arch. That if you do have to go, just that I don't want anybody to say, this can't be done. It's impossible to sequentially distalize those teeth or to bring these into the right position or to whatever. The main point is that I just want you to have that information to know that, yes, this can be done, but it's going to take time. It's going to take planning. Okay. So are we correcting to class 1 molar? Yes, we are. So we're going to sequentially distalize is how we're going to do that. Curve of Spee. Do we have a more significant curve of Spee? So do these lower incisors stick up? Yes, they do. At the end of treatment, have we flattened them? Yes, great. Are we expanding? Yes, some expansion is happening. As we distalize the teeth, we're also going to develop our arch. And so are the 6s parallel? And did we use buccal root torque? The 6s, the buccal surfaces are parallel to one another, and we did add buccal root torque. The smile arc, what do we need to do? Well, when we look at her initial position here, we pretty much just need to create alignment of these teeth, a little bit of intrusion maybe of her upper right, and slight extrusion of her upper left. A little bit of extrusion in that upper right to level the gingival margins. Okay, so that was our smile arc. Next, IPR for fragile tissues. Does she have a concern of recession? Yeah, maybe. I mean, these teeth are more crowded than the last situation. The tissues don't look terrible. So we could keep this as a maybe. We do have it actually planned. I'm currently actually showing plan number 4 instead of plan number 1. I guess we did have IPR in plan number 1 as well. So yeah, we might want to consider some IPR for fragile tissues. The next one is, do we need to do IPR for a Bolton discrepancy? So we click on the Bolton tab here, and this is showing that she does have an excess of tooth structure in the lower arch. So the lid and the box, how they coordinate and fit together, it's showing that the lid and the box are not quite coordinated the best. And so it's not 2 millimeters of larger lower teeth or smaller upper teeth, but it's close to that. And so in terms of the Bolton discrepancy, if we want to correct class 1, what you will notice is eventually you're going to run out of overjet if you don't plan in any IPR on the bottom. And so in this case here, we are going to plan an IPR on the bottom. And notice how the IPR is only going to actually happen once the contacts are all derotated. Because if we try to do IPR between, for example, this lower canine and the lower lateral incisor, we're not going to be doing IPR interproximally. We're going to be doing IPR on the cingulum of this lower canine. It's going to be terrible. The tooth is going to be completely destroyed because we need to do the IPR interproximally. So either we need to do IPR between the premolars more if we think that there's going to be recession, or if we think that the tissues can handle the expansion, then we can do the IPR once the contacts are all open. So that's what this is asking here is, or I guess that's coming later, it's going to be, is the IPR occurring when the contacts are open? But in terms of IPR for the Bolton discrepancy, yes, the IPR is going to allow us to finish in a better position because when we click on Bolton, we can see here that we do have a Bolton discrepancy where the lower arch is larger than it ideally should be. So that's the IPR situation. Are there cancer midline shifts there or not? Other than the little cant we were showing. Okay, so maybe we would say, okay, we need to actually do IPR. So if we were worried about recession, I would say consider placing the IPR in the premolar region rather than the anteriors, or choose contacts like between the central incisors. That's a great spot to do IPR because it's not derotated, or it's not rotated. Okay, but in this case, we're actually okay. So staging, is there round tripping? So are teeth moving one direction and then moving back the opposite direction? Well, you can see that we actually do create a bit of space like we did in our last one here, where we're actually allowing some space to occur so that the rotations happen. But in terms of things moving pretty much from the initial position to the final position, it's happening pretty continuously. So I don't think there's round tripping. Are we extruding any teeth? Well, yeah, the 1-2 is extruding slightly, so maybe we want to consider a specific attachment on that one. So let's leave this line here and go to the next ones. Are there any black triangles? No, no black triangles. Is IPR occurring when the contacts are derotated or open? Great, it's happening here at tray 48. The contacts are derotated. Now again, this is just meant to say not is it occurring at intervals of 12, but is it occurring all at the same time? And it is, right? Because it's so clinically inefficient. You know what I hate about ClinChecks or any treatment planning software is when they're putting in IPR and it's happening at tray 4, 9, 12, 16, 32, 39, 43. Are we expected to bring the patient in clinically at all those different time points? What a waste of chair time, right? We have control over when you want to plan the IPR. Now, even in Invisalign's template, you can actually specifically tell them that you want the IPR to occur when the contacts are derotated and when they're accessible. So they've realized that that was a problem and have made adjustments to that. But yeah, ideally here, we plan the IPR when we want it to occur. Just like with braces. When I did IPR with braces, I chose when I do the IPR. There's no staging telling me this is when you do it. And the next one here, same thing, attachments. Are any attachments going on mid-treatment? No, they're not. Is the number of trays appropriate? Well, we have a lot of trays, 70 aligners. Now this patient is going to be eating with their aligners in. They have attachments on the lingual surface. So we'll be looking at that, but 70 aligners, if they're changing every 3 days, is actually, well, 10 aligners per month, so it's 7 months. Now, realistically, we know that we are going to have a lot more than 7 months of treatment here. We're pulling an impacted canine. It's going to take us like for sure 1.5 to 2 years. And so the reality is here is I'm not worried about seeing 70 aligners because it's a really hard case. It's going to take time, and that's okay. So is the number of trays appropriate here? I'm not too worried about it, to be honest, because doing hard things, if you're going to do a case like this, will take time. So now the next section here, Pontic's and eruption compensation. Well, we are going to want to have a fake tooth for this patient. So yes, we need a Pontic. Is in the right spot? Yeah, it's in the 1-3 position here. We have no eruption compensation. We don't need distal bite tabs. Now, is this Pontic changing size? Is it adjusting, or is it staying the same? Well, it's pretty much staying the same. We can adjust the size if we want to make it a little bit bigger. I think I did actually have them make it a bit bigger. But This Pontic is completely fine. You could leave this exactly like it's shown here. Okay, attachments. Retention attachments, let's start with those. Are we correcting a deep bite? Yes, therefore we need to have horizontal attachments on all of our lower premolars, unless there's something specific like a big rotation. So let's just toggle here to show you what we actually did. So I changed out some of these attachments on the lower, like the rotation attachment on that premolar. I don't really care as much about the rotation. I care more about the anteriors and rotating and improving the deep bite. That's more of a concern to me. So we change out the deep bite attachments. Expansion, are we expanding? Yes. So we need to have some type of attachments on our uppers, on the molars. We do. On our upper lateral incisors. We do. They're on the lingual side here. Do we have difficult movements? We do. So here's a difficult movement, our premolar on the lower. And so what we've actually asked the technicians to do here is to place a double stacked attachment. So we've asked them to place an attachment directly on top of one another. Because the rotation of this tooth is so challenging, what we've actually asked them to do is to create space around the tooth, but also to double stack the attachments. So the attachments are double stacked. And so think of this like wings on an airplane, helping that tooth rotate. Now, you'll see that this actually works really well. This is how I would rotate a lower premolar. If you just have a single attachment on our lower premolar like this, it is not sufficient to be able to create the rotation. It's not going to happen. That's why we have the double stacked attachment. So you have to specifically ask in the instructions to the technician to place the attachment directly on top of the other attachment to make this 3 millimeters wide. Because normally the thickness of the attachments is only 1.5 millimeters, so 2 on top of each other makes 3 millimeters. That's going to help you with the rotational movement. Other challenging movements. Look at our canines. Our canines are rotating a ton. So I've asked them to change out the attachments on my canines. Well, not asked them, I just did it. Because on my canines, I don't want this dinky little rotation attachment. It's the worst. This attachment isn't going to fully probably express the movements. And if it does not express the movements, I'm going to have to put it back on again because these optimized attachments have to be replaced every single time. So instead, I'm going to change the attachment for a tall vertical attachment, which is going to help me rotate that tooth. And if it doesn't fully happen, which you'll see here, we actually don't finish the full batch of trays because of how the trays were fitting in the posterior in the top. You know what? It doesn't matter because this is what you're going to see is we did not make it through the first batch because things stopped tracking with the distalization. Well, who cares? I've got the attachments in place. Everything's where it needs to be. I'm not wasting time with a new appointment or anything. I just get a new batch of trays. The attachments all stay exactly as they are, and we keep going. That's jumping ahead. So that's why I love using this vertical attachment for super rotated teeth that have a lot of root tip as well, because you just leave the attachment on. You don't need to change it. Okay, so that's our rotations and difficult root movements. The canines on our premolar here, the vertical double stacked attachments. On the uppers, we just need attachments of some kind to help with the expansion. Ideally, they're actually horizontal attachments like you see here and not the verticals. But I use the verticals because I wanted to try to control the teeth as we were distalizing them. Now we're using elastics. We don't have any crowns. So let's go ahead and look at our elastic situation here. So do we have a significant change in the anterior-posterior? We do. We have more than 2 millimeters. So why in the last case did I not use why did I not use this sequential distalization? Well, when you look to see how much we need to back these teeth up, so from this molar right here, here's our line. It's 1, 2, 3, 4, 5 millimeters. We are sequentially distalizing the teeth 5 millimeters. We know that we could get maybe 1 to 2 millimeters of anterior repositioning if they're retroclined and we expand and arch develop. But 5 millimeters is a ton of movement in the anterior posterior. We cannot rely on just the condyle repositioning itself as we fix the retroclined teeth, right? We have to do something else if we want to correct this to class 1. And so because we do, we're going to use the technique of this sequential distalization. Right? So the teeth back up one tooth at a time. So what is crucial in this plan is that we are using elastics from this upper premolar to the lower second molar. That is what is helping pull back all of these teeth. What we're doing in this region here with the hooks is we're using this to actually hook on our impacted tooth, because what we're going to do then is we're going to uncover this impacted tooth using a laser. So we use a laser and we remove the baby tooth and we uncover the impacted tooth. In this case here, I wanted to see if the tooth would auto-erupt first, but it didn't. The tissue started growing over, so we actually place onto that tooth a button. So we place this button onto the tooth and we use an elastic then to hook onto the lingual side of this tooth. So from the lingual, this upper canine, down to the slits on the lower in a triangle. So that just pulls that tooth in little by little by little. So we're going to break this out a little bit differently than how I did the last case, but essentially let's just look here to see just what's going on with this canine. So we surgically uncover it. We see if it'll come, it won't. We put a button on it and we run the vertical elastic. Once we've pulled that tooth in enough, it's very twisted. But at this point here, that's fine, because what we can do is we just get a refinement, right? Let's say that we see this canine is coming in, it's twisting while it's coming in. Why do we need to use the entire batch of trays? Why don't we just go ahead and say, you know what? Why don't we get a refinement now? And in this refinement, we will incorporate that tooth now into our plan. So let me just pull up that ClinCheck for the canine specifically. So we're pulling that canine down using a button elastic, and we get to this point here where the tooth, there's the lingual side of it, is now partially in. Now here's the tricky thing, is that we actually cannot, on this canine right now, actually fit an attachment because the tooth is too small. So you know what I do? I literally take a blob of composite and I build up a blob of composite here on the buccal to actually create, before we scanned them again, my own attachment. It's just composite I threw on the tooth and then we scanned them. And so all of this is just my own custom composite to help with the spinning and rotation. So here's where we were on plan 8. And then here's where we are at the start of 15. Right? So from here, again, we took off the button. Now that the tooth is pulled in enough, I put on a blob of composite right here, and then we spin that tooth and rotate it. And then at this appointment here, we actually changed it out for a button to help with more of the class 2 correction still. Because we were using this white button on the premolar for our class 2 correction. Well, now we can change this out for a button as well on our canine. So I'm jumping ahead here. We're talking more about the class 2 correction still, but let's go ahead and address the class 2 correction throughout the ClinChecks then. So that's the canine pulling in. In terms of the class 2 correction, well, we've got the sequential distalization, but this patient comes back in and their trays are not fitting the best. Right? We've backed up the second molar, we've backed up the first molar, but it just isn't tracking. So you know what? Who cares? It's not a big deal. Just take a new scan. You know what's going to be amazing is when you take a new scan of this situation right here, it will now track so perfectly. It will fit so perfectly because when you scan them, you're actually scanning interproximally between those teeth. So now we go ahead and we just get a new batch, keep going. So we finish, let's put the bottom arch in too. We finish distalizing, then the first molar, then the second premolar, then the first premolar, then the anteriors. Well, where are we at the end of this batch? Well, we're better, but we still need a little bit more too. Right? We started working on the premolar region, but maybe our molars have drifted forward a bit. So no problem. We distalize the second molar, then the first molar, then the second premolar, then the first premolar. Now that canine was coming in. So now the canine can rotate too and back up. So then here's where we are after the third batch of trays. And again, we haven't gone through a full set on any of these even. That's one thing that I expect in these hard cases, that we likely won't make it through the entire batch. Well, now all we're doing on this batch is we're just settling the bite a little bit. That's it. Because we've accomplished the class 2 correction. So we're settling the bite and ensuring that this canine is in the right position. Okay, let's look at the other side. Again, I'm kind of breaking this out differently here because on this side here, we've got our lower premolar. So what happens after our first round of trays? Well, it started to rotate, but we actually lost the attachment off our lingual. But because we have such a good, huge handle to spin this tooth on the buckle, we left it. So we're just gonna work with this attachment because I didn't want to waste chair time putting an attachment back on when I thought this can get the job done for me. So we leave it. We just spin this tooth. And this is what we've actually accomplished after our second batch of trays. So that tooth has fully spun. From here to here, it looks great. Now here's a secret that I will tell you. Yes, did we get some distalization on this case? 100%. But look at the beginning position. Look at how these teeth in the anterior are super retroclined. One thing that will happen again is as you procline those teeth and you widen the arches, the mandible will come forward. And so that's exactly what ends up happening in this case here. Right? We didn't sequentially distalize this side at all. But yet, when we look at the position, this is after our first batch, we didn't get all the way done because we jumped into that mid-course correction. This is another part way through. As we've developed and expanded the arch, what's happened now, which is quite interesting, is that this patient now is in a class 1 occlusion. But they've actually gone into a bit of a crossbite. They have a functional shift because the mandible has actually come further forward. Right? As the mandible came forward, they were kind of biting like this in class 2. And then as it came forward to fix, and they actually, this patient, I didn't mention this before, but they had some TMD clicking and popping. So that's why I knew the mandible would probably come forward. They're actually coming forward, but they're coming forward slightly into a crossbite. So what do? Well, the first thing we don't do is we don't freak out. Instead, we put some buttons onto these teeth on the lower buccal to the palatal of the upper, and we run some crossbite elastics. And we do arch development and expansion. Right? You can see how much we're developing the arch with our crossbite elastics. And we overtreat. So we actually finish in a position that's more, it's almost like a scissor bite. We've almost put this patient into this scissor bite. Because we know that what we plan on a clinch check often does not happen. So if we know that we start here and we want to finish here, we actually have to finish the clinch check to be here. We've got to overdo it. So that's what we do, is we overdo it. And what does our plan look like then? Well, we didn't end up getting everything we asked for. We got half of it, which got us out of that crossbite. So now all we're doing at this point is what we've previously talked about. We need a little bit of bite settling, right? The contacts between the teeth, because of all the plastic that's been between them, it's a bit flimsy. And so from here to here with 17 to 20 is just simply allowing the bite to settle. Go back to our photos so I can show you there too. Right, so we're kind of in this spot right here. The bite's not quite as tight in certain areas as we want, so we take off all the attachments. We ask the technician, right, to remove attachments and to just settle the bite. We give them 6 months of these trays and tell her to wear them for 16 to 20 hours a day, and we let that bite settle. Just like that. So then when she comes back, unfortunately the pictures are a bit washed out here, but the bite has settled really nicely on both sides. Our midlines are perfectly on. Our deep bite is corrected. Her canine that was once impacted has been brought in. The only other thing I'll mention is that what I will sometimes do at this point is I will take a laser and I will actually laser off some of that extra gum tissue because the tooth is still kind of immature with those gums. So I just lasered off the gum tissue, and then that gives us the same or the closest we can be, at least at this point, to mimicking the symmetry on the other canine as to this one here. But this will take a bit of time. It will balance out more over time. So from where she first started to where she's at the end. And if you join Clearly Select, then you'll get access to all of the courses that are available. So there's 5 different courses: foundational systems, attachments biomechanics, diagnosis, development, and treatment planning, mixed dentition, and there's a mixed dentition part 2. And then right now we're finalizing getting the content for a teen. So unfortunately, it's a much longer topic conversation, but that's what I'm trying to do here, is to specifically show like clinical circumstances. And can we get 2 of these? Can we get templates for the actual ClinCheck itself? That's where, again, being a part of Clearly Select, which if you're interested in more information regarding Clearly Select, I don't know if it's in the chat already, but I'll just share this on my screen. With Clearly Select, this is essentially the information page that gives you information about what Clearly Select is. Here is essentially just the courses available that I was just talking about. So foundational systems, attachments biomechanics, all of the different courses. And there is packages to receive discounts and savings if you want to have multiple packages. So this is the specific for our, and this is all in Australian dollars as well.